Okay, very good. Our topic for today is going to be on the patient assessments that we do in the sleep lab, as well as the documentations, the importance, etc. As sleep, we are the eyes and ears, the mouths, the voice. We do so many roles in the sleep lab, but we will focus on the patient assessments and what we do when the patients are already in the lab. The way I discuss sleep technology is I always group everything I teach into just three parts, three main parts. Everything you need to know before the patients come and arrive in the sleep lab or the clinic, everything you need to know while the patient is in the sleep lab or clinic, and then everything you need to know when the patients leave. Okay, so that's how we will break it down. I always remind everybody that so you can always have a separation of your understanding, separation of your buckets. If you fill your bucket one, bucket two, bucket three, your bucket one, you fill it with everything before the patients arrive, and then so on. Is that clear? Good. Now, introduction is what is sleep technology? We record people and then we go to sleep. While the patient is asleep, we go to sleep too. So what is sleep technology? It first do the technical portion of the study.
Monitors, diagnose, and treat sleep disorders, sir.
Very good. Yes, we monitor and diagnose and treat sleep disorders. We work hand in hand with the sleep specialists. So we follow what they need in order to address the patients. But the most important part there is that we're enabling the sleep specialist in conducting what's needed for the patients to get diagnosed, to get the patients treated. And after that, the long-term clinical management of the patients, because sleep, most of the time, most of the disorders are chronic. What do you think?
Chronic.
Absolutely. Sleep most of the time are chronic disease. You might have some patients who suffer from acute insomnia, so that can only last about 2, 3 weeks. But for the most part, majority of the people that we see in the sleep lab that we test are suffering from chronic diseases such as obstructive sleep apnea, chain strokes, etc., etc. Very good. So the importance in diagnosing and treating sleep disorders is because this is the system of how the patients go from being diagnosed to getting treated. The way I teach here is based on how the United States system flows, simply because all of you eventually will become RPSGTs. And if you are, your understanding, your standards based on the United States. Okay, let's just be clear. We can have differences in how we do things in the Philippines, in Malaysia, in Saudi Arabia, in UAE, or even in Canada. But we are going to be RPSGTs, and that means the US standards. So the US have established all the standards. We follow the American Academy of Sleep Medicine, we follow the American Association of Sleep Technologists, and the RPSGT, which all of you should become RPSGT soon. RPSGT is under the Board of Registered Polysomnographic Technologists, BRPT, and that's also based in the United States. So I want that to be clear that if your understanding is a little bit different, how you do things a little bit different, I want you to voice it out so that we can clarify that whether maybe that is based on your country's healthcare system or whatnot, but make sure that you clarify everything here in class, okay? Now, as sleep technology is really a multidisciplinary field. So majority of you are respiratory therapists. Some of you are nurses. I have one student right now doing our PhD review, and his background is in, I think it's in philosophy. So it could be from different perspective. It's an advantage if you are in the medical field. It's an advantage for those who are RNs, RTs, medtechs to be in this field simply because you are already familiar with the terminologies, many other aspects of medicine. However, sleep is a unique medicine. It's a unique medicine because it involves all different aspects. Just for example, when you do a sleep study, you put electrodes on the head, and that's the neurological perspective. We monitor brain waves, we want to see sleep stages, we want to monitor arousals, etc. And yet we also put EKG pads so we can monitor the cardiological perspective. And then we monitor also the electromyogram, monitor if the patient grind their teeth or do they have leg movements, do they have periodic limb movements at night, do they kick? And so it's a very unique and multidisciplinary field. We, the techs, are the one who really prepare the patients in the polysomnography portion of the patient treatment. We eventually lead to treatment of the patients. What's most appropriate intervention for the patient, right? Now, having the knowledge of the appropriate preparation for the patients and monitoring leads also to how the patients can be optimally treated. But as sleep techs, we don't just prepare the patient for a sleep study and go ahead and do your study at night and then tomorrow we kick you out of the lab. We monitor the patient, but we also ensure that the patient is safe. We monitor that the patient is comfortable, okay? And we also focus on having a good quality acquisition, which is the recording of the polysomnogram. And then we make sure that all of the documentations are complete, or at least as much as possible. And here, Professional Conduct Inc., this is in regards to how we address the patients and the standards of our interactions with the patient. So, patient prep monitoring. This is when we ensure that the patient is hooked up appropriately. I have a class on the International System of Measurement, the I-1020. Is everyone here familiar with the I-1020? Have you heard of the I-1020? Or did you practice, or do you practice it in your labs? But if you see how the hookup usually for a polysomnogram is very aligned, it has a very nice channels. It looks more like, if you see a study that's messy, usually that's because they didn't follow the International System of Measurement. I have a recording that you will all be able to access on how to perform this correctly. And when you're ready, you can view that recording, or you can wait until I conduct the actual class. But the International System of Measurement is one of the key tool that we have. As it's almost saying, if you are a carpenter, you always should have a hammer and a measuring device. Otherwise, you're missing one of the most important things that you need to have. Having appropriate measurement enables us to put the correct positioning of the electrodes on the head. And if we have the appropriate positioning or the sites, then we optimize the actual recording outcome. Let's say you have the frontal area. This is where we monitor the big waveforms, the delta, the K complex. That's all in the frontal area. But if you're not paying attention to your positioning of electrodes, you move towards the back or towards the middle of the head, then you will lose the appropriate voltage, okay, how big the signals. And so it leads to a possible incorrect staging and eventually can affect the patient's outcome. And safety is most important all the time, regardless. You're dealing with patients that have entrusted you. So we have to always be cognizant or aware to maintain safety. And safety, not just in the sense that the hospital, the sleep lab is secured, but we also look into patient safety and comfort in a sense that we make sure that we follow guidelines and protocols that are necessary. For example, when you have to restart a sleep system and you already have started the study, so the patients are connected with the head wires to the head box, to the amplifier, to our computer system. If you need to restart that system, it is mandatory for you to unplug the head box. It is mandatory for you to unplug the patient from the amplifier. It's a no-no to restart that system with the patients plugged in. Okay, that's just one of them. If you have a patient and the patient has known epilepsy, or they have multiple seizures, you have to make sure that the bedside rails are up, and you can also have seizure pads. Usually, if you don't have seizure pads on the bed rails, you can have pillows on the side. So if the patient has a type of seizure where they trash and they have spasms, etc., you have to protect them. Okay. So these are some of the things that's important safety-wise. Comfort, on the other hand, is a different story. Sometimes it's difficult because you're trying to finish your job, and sometimes the patient is taking a while to become comfortable. Maybe they don't want to get hooked up yet or wired up. Maybe they need to use the bathroom. Maybe they arrive and they're hungry. I don't want to hook up yet. Let me go eat. So maybe they have many other demands. Otherwise, they will not be comfortable with you, and maybe they'll walk out. So there is a balance of how do you approach the safety and make sure that the patient is comfortable. And this is also very important when it comes to your infants or pediatric population, as well as your geriatric, the elderly. The elderly, usually, if I have an older patient and I'm monitoring at least 2 patients that night, I will usually choose the bedroom closest to the bathroom so that when they need to use the comfort room, it's a lot closer to them. They don't need to walk too far. Some sleep labs have their own restroom or comfort room in their own rooms. This is what I have now because I operate a sleep lab in a hotel. So each patient, and they have their own restroom or bathroom. But comfort also, it comes to you should be able to understand what the patient need is. And that's why we did the age-specific class, because it prepares us for these scenarios. For example, you have an elderly. Elderly, usually, they don't really sleep well. They sleep very light. They usually need to use the restroom more often. That's when you get older, that's when you start to have bladder problems. So when you consider the elderly ahead of time, you can offer them ahead of time either having a commode, bedside commode, or having a urinal. And also, they usually get cold quicker compared to young adults. So you have to make sure that these elderly have extra blankets. You don't make sure that the room's not too cold, or you ask each patient, is the room comfortable? Do you need a fan? Do you need to increase or lower your temperature here? Let me pause. Questions? No questions? Going towards data acquisition. So data acquisition, this is when you deal with the computer system. We have to make sure that we have really good preparation for the electrodes, the sensors on the head, on the face, the belts, the EKG, the leg monitors, pulse oximeter. Sometimes we use capnography or CO2 monitoring. Make sure that everything is calibrated, and we do a patient calibration. But the most important thing there is that when we start the acquisition or the recording of the polysomnogram, that everything is very clear, readable, and appropriate. You don't want to start a study with all these artifacts going on when you can barely read the sleep study and you keep going. You have to start the study on a good note, on a good recording status. If you end up with some artifacts in the middle of the night, you have to troubleshoot quickly. And that's some of the things that we will learn also moving forward, because I do have a lecture. It's already a recorded lecture, but I will again conduct a session like this on artifacts and troubleshooting. So documentation, on the other hand, is very important, because in the medical field, everything you do is legal. People can get hurt. People can come back and say, something happened to me in the sleep lab. It was the tech's fault. It was the doctor's fault. They didn't do this for me. So that's why documentation is very important. That's why recording is important. The video recording is important. The audio recording is important. And documenting whatever happens on the study itself. Some of you might be still using paper, annotating on paper, but for the most part, the newer sleep systems, you can annotate everything within the computer. And it all automatically, the note with the timestamp, whatever you hit enter, when that note is entered, that's when it happened. So remember that you need to document more instead of less. I usually document just the regular one every half an hour. I will always mention the patient is asleep. on N2 sleep, no signs of pain and discomfort, bed rails up, SpO2 at this time is at 95%, and then every half an hour I do that. So the doctors can walk in the morning and see my documentation. If they see that it's just the regular documentation, they don't see patient got up and had issues, then they know it's a very quiet night, just because I documented every half an hour. And professional conduct, you are in a setting where the patient is staying so long in their appointment. They can get very uncomfortable, they can get very anxious, they can get very aggressive, or they can get really upset. And if they have to deal with you for 8 hours at least in the sleep lab, the best way to approach each patient is to stay professional, okay? Because the patients can become really friendly with you, and they can get a little bit pushy. They can push you, they can test your limit, they can joke around, but at times some of them becomes really inappropriate, and you don't want that. The way you guard yourself is you maintain a professional conduct. Again, the way you communicate is professional, because if you start to become also aggressive and inappropriate, that can lead to something worse. And the patient can turn around and say, oh, that tech said this and that. Because you were comfortable, then you think it's okay, but sometimes it's not. So the most important thing for us to do is to stay professional the entire time. Okay, thank you. Now let's go to polysomnography. What is polysomnography? It's a mixture of, again, neurological perspective. We monitor the EOG, or the electrooculogram, monitoring the eyes to really identify, is the patient awake or asleep? Is the patient on light sleep? Is the patient in with the eye movement? And so then we monitor the snoring, the respiration, the electromyogram, or do they grind their teeth? Do they have any arrhythmias? Do they have irregular beats? And then we also do all the titration, CPAP and bilevel titration. We can go further into the ASV and the volume assured pressure support. So we will actually have a really good session on titrations, because this is one of the biggest portion of the knowledge that we have to have, and also a portion of the examination. So for those who are taking the RP exam and those who are new to sleep technology, this is one of the things that you have to focus on. How to perform it appropriately and within the standards of practice according to ASM and BRPT, and also the titration, very big topics. And so this is a separate discussion, because it will require at least an hour or two to discuss all the modes of titration. But multiple sleep latency, if you perform PSG, like the overnight, you can perform MSLT even easier. The key to MSLT, multiple sleep latency test, this is a daytime study where you do 5 naps. You do 5 naps every 2 hours. But the patient usually will have a minimal. They will not have the entire sensor set. They will do usually an overnight study, and then in the morning when they wake up, you will take out the other parts of the sensors. You'll take out the flow channel, they don't need it. You'll just maintain the EEGs, the EKG, and the EMG. You'll take out all the respiratory belts and the leg electrodes. So MSLT is to monitor for narcolepsy, to diagnose narcolepsy, or if the patient is suffering from excessive daytime sleepiness. And then we also perform home sleep apnea test, or HSAT. This is sometimes called HST only, home sleep test, or OCST, out of center sleep testing. So don't be alarmed when you hear different words. This is just a standard where we use different terminologies, but it's the same thing. You can hear, oh, we're doing HSAT. Oh no, we're doing HST. Oh, we're doing OCST. It's all the same. This is home sleep testing. This is where you have very minimal sensors on the patient, typically the flow, you have the snoring, and then you have oximetry. Now, I do have a lecture on home sleep testing alone, because this has evolved into a much larger technology. And here in the United States, this is the main mode of diagnosing patients with sleep apnea. Majority of the patients have sleep apnea, and majority of the patients now are getting diagnosed with home sleep testing. They only come into the sleep lab when they need titrations or they come back and they require additional testing because they might have comorbidities. Comorbidities such as maybe COPD, hyperventilation, neuromuscular disease. So when you have those comorbidities, you cannot just do home sleep testing. You need to do an overnight study. Now, when the patients come in, most of the labs will require at least a blood pressure check. Patients come in, we always check for blood pressure. When COVID era was around 2019 up to 2021, we had to take temperature. We actually stand outside with our mask, okay, with our gown and with the temperature, a thermometer. And the patients are not allowed to come inside the sleep lab until we check them. If they have a high temperature, we send them home. Okay, they cannot come in. But if they are okay, then we do the blood pressure as soon as they come in. Why? Because if the patients show that they have 200 over 100 blood pressure, you have to recheck that on the other arm. You wait 5 to 10 minutes, up to 15 minutes, then you check the other arm. If it's still very high, you need to call either your medical director, your lab manager, or the on-call doctor to mention about this patient with really high blood pressure. But the third thing you have to do is you have to check it manually. If it stays high on the one arm, you move to the other arm, still very high, then you have to get your manual sphygmomanometer and check, okay? Then if it's still high, you have to call the doctor and clear whether the doctor will tell you to resume the sleep study or send the patients home, or when the blood pressure is really high and the patient has a history of myocardial infarction, stroke, or anything that leads to that. If the patient is taking medications for any cardiac problems, then you need to also send the patient to the ER or urgent care, okay? And it happened to me a couple of times. It also happened before where I had to call 911. So you have to have an emergency protocol when these things happen. But going back to the baseline, we need to take the patient's blood pressure. Okay? Is everybody here taking blood pressure? Everybody comfortable taking blood pressure? Thumbs up?
Yes, sir.
Yes. Very easy now. Good. Because now you can just have the automatic one. You can even have a wrist one, right? There's a wrist blood pressure cuff. And you just put it in and it runs on its own. Now, assessing the patient with the vital signs is very important, but we also monitor for patients' contraindications. Now, sometimes the patient will have severe COPD. Maybe when we look at the chart, when we come into the sleep lab, first thing that you need to do that we discussed in chapter 1 is that you check the patient's chart. So you know the type of patients that are coming in. If you look at, say, Mr. Jones, you look, oh, Mr. Jones coming in for a bi-level titration. You look, oh, patient has severe COPD. Wait a minute, the patient was just in the ICU 3 weeks ago, okay? So you have to be watchful of these types of patients and be prepared. If my patient was just in a hospital about 3 weeks ago, I will make sure I have my oxygen ready and my AED ready, okay, in case this patient ends up with any type of respiratory distress. But typically, when you titrate a COPD patient, when you are in appropriate bi-level pressure, then you actually help them that night. It's an amazing experience when you see this severe desaturations. And I've seen COPD patients of mine with oximetry down to the 40s, sometimes 39% oxygen saturation. It's mind-blowing because, wow, how can you live like that? But then I put them in a CPAP. Of course, they don't do too well on CPAP if they already have severe COPD. Typically, if COPD is just at the beginning stage, they can still get better with CPAP. But eventually, they will have air trapping or CO2 retention. So what needs to happen is really they need to be titrated with a bi-level machine, the bi-level mode. And eventually, when they get worse, they will need to have a bi-level ST or with a backup rate. So I'll explain all that on advanced titration class. Any questions? Again, what we assess and why it matters because when we assess the patients appropriately, we improve the patient's comfort and cooperation. Remember, in the sleep lab. They need to be diagnosed and treated, but if they're not comfortable, they can walk out. They can get mad at you. They say, forget this. They rip off the CPAP mask and I'm going to leave. It happens. It happens, and it happened to me. And so even when you try your best, it could still happen. So it's really important to stage everything, to make everything calm, professional, and that you make the patients feel you're there for them. You don't know if this patient heading to the sleep lab, they almost got into a car accident. You don't know if they were just fighting their wives or their husbands or their children before they went to the sleep lab. You don't know if somebody just died in their family. You don't know just what happened before they got into the sleep lab. And when they get to the sleep lab, you're there, hey, by the way, I need you to hook up, please. I need you to hurry up because I have another patient. That can just escalate quickly. As techs, we need to be very good in psychology. They don't tell us this in any of the curriculum on any training, but really as sleep techs, you need to be very aware because the patients have to stay with you for many hours and the patients know you're watching them. It's a very odd scenario for anyone. Would you be okay if you know that a person is looking at you all night? And if that person is not friendly to you, you don't know what's going to happen. So it can escalate quickly. That's why we as techs have to be understanding, we have to be calm, we have to be professional, and we always need to balance both the patient's safety, comfort, so that we can have their cooperation, okay? And this is really difficult when it comes to children. It makes it even more difficult. So for those who see children, pediatric population, I salute you because it's very difficult. I've had some children before, but I am not a pediatric sleep tech. I have worked in sleep labs where we saw different patients, including peds, but it's not my daily activities. Again, being accurate as sleep techs leads to having accurate data for the patients to have to present to the doctor and get them to a most optimized and accurate interpretation, therefore accurate and correct diagnosis, treatment, and clinical management. Very important. The higher the standards we practice, the better outcome for our patients. Talk about sleep habits. Now, the pre-study interview is very important because some of the patients will not fill out their forms ahead of time. Sometimes we send them the forms, the questionnaires in the email, or they will fill it out in the sleep lab. But sometimes the patient will fill it out correctly or completely. And so it's important to have the discussion, talking with the patient. This, you can educate the patient and have some further assessments as you are putting the sensors on them, etc. You can have more answers while you're hooking them up, while you're adding electrodes. Sometimes they'll mention that, oh, by the way, I have incontinence. They didn't mention it before, but now that they see that you're nice, you're professional, and they feel comfortable with you, they can mention, oh, I have incontinence, so I use diaper. So when they say something like that, then it adds to your preparation. Then you can act quickly. Patients with incontinence, usually you will add another pad on their beds so that if they ever pee or soil themselves, then you are ready for it. And it's important to let the patients know that they can take their current medications. If their medications include drugs that will affect their sleep studies, then you need to contact the provider or the doctor. Here in the United States, we call them sleep providers because not all of them are MDs. In sleep, we have MDs, we have doctor of osteopathy, we have PhD psychologists, they are sleep specialists. And then we also use APPs or advanced practice practitioners. These APPs are your physician assistants and your nurse practitioners. They usually have a master's degree or a PhD as a nurse or as a physician assistant. So they can perform what a sleep specialist performs. They usually just need to be signed off by an MD, but we call them sleep providers. So don't be confused if I mention sleep providers. And when I say sleep providers, it's all of them included because they're not just all doctors. Allergies and medications. Now, why should we be concerned about allergies and skin conditions? Why? Somebody tell me why? They're doing a sleep study. Why should we ask them about allergies and skin condition? When we do sleep studies, we use a lot of tape We tape the skin, we tape the EOGs, the ground, the back of the ears as reference. Tapes also on the EKG. We use at least 2 to 3. We used to use 5 EKG pads for research, but we use a lot of tape. And some of these patients are sensitive to tape. Some of them will have rashes by the time they finish, or even when they just first start getting taped, they already start to itch. So we have to be careful because some of these patients, they need to be either placed on a particular type of tape. Paper tape makes it very difficult to stay, but is the only thing that they can accommodate. And some of them are too sensitive that you can't do the sleep study. Okay, not common, but it happens. So we have to be careful. And claustrophobia, it's true. Some patients, as soon as you try to put them on a CPAP, they freak out. Okay, they increase their anxiety. So we have to understand some of these special needs. Some of these patients, if you deal with pediatrics especially, you can be dealing with patients who are mentally delayed or retarded. Some of these patients have Down syndrome. So mental retardation, you might have a 15-year-old, but they will act as if they're 2 years old. So you have to treat them on the age level of or their understanding. And we utilize their caregiver or their parents a lot in addressing the patients. You don't just interact with the patients directly. You need to build the trust. Pediatric is very tricky, but very rewarding because they are very underserved. Here in Los Angeles, for example, Children's Hospital has a sleep lab, and patients have to wait 1 year to be seen in the sleep lab. They wait 1 year to have a sleep study. Can you imagine waiting that long? How long is the wait? Some of you are already sleep tech. So how long is the wait there? How long is the wait?
About a week lang po, sir.
Oh, nice. Good. Very good. 1 week. In Malaysia, Hilmi, how long is the wait in Malaysia?
4 to 6 months. Yeah.
Oh my goodness, so far.
Yeah.
Saudi. Here in my lab, it's about a month, 1 month. But to get the results, so we have both the sleep lab and the clinic. To get their test result, they have to wait 3 months. It's ridiculous because we don't have enough rooms for the clinic. So the sleep lab is not too busy, 1 month wait, but to get their test result, it's 3 months. So what we do is we put the result in the patient's electronic medical record so they can access their own test result. We just also notified their primary care physician, hey, Dr. So-and-so that is taking care of this patient, here's the result. So you can discuss it with this patient, because when the patient wants to see our doctor, it will be about 3 months. So they can start to engage and talk to the patients and then ask our doctor, maybe we need to do treatment now. So it can move forward that patient treatment, okay? So special needs, Down syndrome, the elderly, non-ambulatory, so patients that have either are old and then they have issues or arthritis, they can't really move much. We also allow these patients to have somebody to stay with them all night, okay? Either their family or their caregiver, the same room. However, when you allow patients to have accommodation and with somebody at night, we also ask that whoever is with them does not snore or have sleep apnea, because we end up having issues where the patients cannot sleep well because the person accompanying them is snoring so loud. Okay, so it's affecting the study. Now let's move a little bit quicker and talk about the vital signs. Okay, the 4 core parameters of vital signs, of course, temperature, pulse, respiratory rate, and blood pressure. Okay, temperature now is not really mandated. Before, during COVID, it is. Pulse, you monitor all night because the patient's connected to the pulse oximeter. So the pulse helps you clarify arousals, okay? It also helps clarify if the patient is really comfortable, relaxed. And usually if there's anything abnormal, then you will see the pulse rate jump up. And you have to be watchful of some patients who are athletic. If you have a patient that's an athlete, a professional athlete or a swimmer, a runner, you will see pulse rate down to the 30s. Usually you monitor between 60 to 100, but these folks, their pulse rate are under 50, under 40, and their respiratory rate is 10, 9, 8. I had a patient, I think he was a swimmer, like a diver, but the respiratory rate was 8, and I could not believe it. I was like, oh my God, from the very beginning, while the patient was awake, the respiratory rate was already very slow. So I thought maybe this is something wrong with my sensors, but it's not. The patient was a very strong athlete, so the very slow breathing and the pulse was so low. But you have to be careful with bradypnea or bradycardia, the same way as you're aware, and be watchful of having any tachypnea or tachycardia. Respiratory rate, blood pressure, of course, I mentioned earlier. Per emergency guideline, you monitor if the patient has a systolic of 200 and higher and diastolic of 100 and higher. As soon as you get 200 over 100, you tell your doctor, immediately notify somebody, and then you recheck that blood pressure. Okay, and if some patients have a normal high blood pressure, that they are always 160 over 95, and they tell you that I've been on medication, but it's always been like that for many years, then that patient has been established as hypertensive, okay? And most of your patients that have true sleep apnea, they are usually resistant to medications, okay? That's one of the major signs of positive sleep apnea, if they don't respond well to hypertensive medications, okay? But when they do end up on CPAP or bilevel, it drops their blood pressure really well. Let me pull back here real quick. Let me ask a question. What is one of the contraindication for CPAP? Has anybody heard of that? What is one contraindication for CPAP or BiPAP? This is an exam question, by the way. Even now for us. Say,
If there is like facial injuries, like that.
yes, so it is contraindicated for patients to use CPAP if they have any facial injuries. And injuries might be from a motor vehicle accident, or maybe they're UFC fighters and they just got punched in the nose and then they do a sleep study. So also if they are hypotensive, if the patients are hypotensive, they cannot be placed on CPAP. Okay, because CPAP can drop their blood pressure many points, up to 10 points. Imagine if they're already 90 over 40 and then you put them on CPAP, then they'll drop to the 70s or 80s over 30s. Hypotensive patients, they cannot be placed on CPAP. Now, pulse and oxygen saturation, as we all know, is important because we monitor for desaturation. It's not only how low is the desaturation or the nadir, and nadir is the lowest saturation that we monitor, that we recorded, because that tells us the severity of the patient's desaturations. How much oxygen do they actually lose? But also how often. You can drop to 70%, but it only happened twice all night. Or you can drop to 85%, but it happened 200 times a night. So which one is worse? So there is now big discussion on the importance of hypoxic burden. Hypoxic burden. Please look it up when you have time, because it's been a discussion circling around different conferences, articles in sleep. Oh, by the way, I mentioned articles. Let me plug in a couple of sleep. These are some of the magazines in sleep. No, that's blurry. Sleep World and then Sleep Review. Oxygenation is very important and it has to be between 95 to 100%. If you have COPD patients, typically they will not be this high. If you have COPD patients and they've been having this chronic disease for years, then you won't expect them to have 95 to 100%. You expect them to be in the 80s and sometimes in the 70s. When they fall asleep, it's even worse. Okay, so again, does anybody know what you call that syndrome when you have COPD and OSA together? What is that syndrome called when you have COPD and obstructive sleep apnea? Very good. Thank you. It's called an overlap syndrome. When you get into the sleep lab and you see your next patient has overlap syndrome, prepare for your oxygen. And typically, if you're able to optimize their bilevel titration, then they might not need oxygen. because then you're able to help them exhale out the carbon dioxide. But some of these patients will still require supplemental oxygen, especially if they've had severe COPD for years. Now, when you have low oxygenation, don't assume that the patient needs oxygen. First thing you should always do is to check your positioning. If you're about to start a study, you start your calibration and the patient's 88, 87. Don't think that, oh man, I need oxygen. No, go there first and check your position. Check if the probe is maybe slightly out. Okay, reposition them to a bigger finger or move to the other hand. Patients also can lose oxygenation if they're sleeping like this. They're leaning on one side and you have the pulse oximeter on this finger. If they're pressing on it and then they have the elbows bent. So you will drop your oxygen levels that way. When that happens, either you move it on the other arm or you just tell the patient, please take off your hand from your face. But if they sleep like that, I would just move it to the other hand. Okay? My mother sleeps like that, so I know some patients, that's how they sleep. Normal breaths, depending on the book that you read, could be 12 to 24 or 12 to 20, the normal breath rate. And then we also use 2 belts in the sleep lab. And why do we use 2 belts? Is because we monitor for paradoxical breathing also. Paradoxical means they're going against each other. When you start the recording, the respiration, the nasal thermistor, and the cannula that monitors the pressure transducer, it will be in sync. They'll be synchronized with the flow of the chest belt and the abdominal belt. They'll be all the same. They'll be in sync. Once the patient is having obstructive events, the thoracic and abdominal belt will go against each other. They will not be synchronized. They will be out of it. They will touch each other. What's happening there is an obstructive event. Okay, and that's how you know. If you start the study and they're already having paradoxical movement, that means you have to change your settings. Okay. Now, this is important because this is how you know whether your patient is having central or obstructive. And again, importance of blood pressure, we already discussed. Using automatic blood pressure machine and moving to manual is very important if your patient stays very high on their BP. Okay, and some of these patients might not have been diagnosed yet, and this is the first time they go to a sleep lab, and you can help them get diagnosed appropriately because of your monitoring skills. You identify that the patient has high BP, and then you notify and escalate this to the doctor or to the sleep providers. All right, we do also physical and behavioral observation techniques. We use a camera to monitor the patients. And why? We want to make sure that the patient that we monitor is actually on their back or supine or on their lateral, left lateral. Are they curled up? Are they actually having leg movements? Are they trashing? Are they moving while they're in REM? So we utilize the cameras for these purposes. And I used to zoom in to patients' eyes. When I see REM, especially high density REM, I zoom in just to show the doctor the high density REM. But it doesn't hurt if you also monitor that the patient's having bruxism, grinding their teeth, and you try to zoom into the patient and pull back. Okay, but majority of the time we use the camera to monitor their position. Okay, and we also have audio. We can talk to the patients in their rooms. So at the beginning of the night, we ask the patients to try to sleep on their back as much as possible. Sometimes we're successful, sometimes we're not. Now, overall, we need to monitor and make sure that the patient's emotional state is in good condition, that they're cooperative. We always try to come up to the patient very understanding. You don't want to come up to the patient and you're demanding. You have to always just be professional. You don't have to be like a slave to a patient. Like anything they want, you will do, because sometimes they will request for things that is not helpful for the study. It's already late at night. Oh, I need a soft drink. I always drink soft drinks right now. And go get me one. So some patients might do that to you. And that's when you can say, actually, no, I can't do that. And that will affect your study. Remember that they are in a medical appointment. Sometimes you have to remind them that this is not a hotel stay, but it's a medical appointment. Okay, but you have to say it nicely. Now, let's talk about skin preparation and electrode application. There are different techniques when you prep the patient's skin. And the most important thing is not to scrub the skin hard. When it comes to skin application, we already use an abrasive prep that we use a cotton tip applicator, like a Q-tip. Sometimes we use lemon prep, which is more abrasive, but this prep feels like it has salt or sand in it. So when you scrub it on the skin, if you prep too long, it will start to hurt because it has coarse material. It's coarse. It has either sand or salt in it. Okay. So remember, when you prep, the key to preparing the patient's skin is that it's equal. You use the cotton tip this way, it hurts the patient. Sideways. Count to only 2 to 3 seconds, but you press. Press 1, 2, 3, next. 1, 2, 3, press, next. 1, 2, 3. The same. If you prep similarly in all spots, you will have good impedance. Okay? Make sure that if the patient is diaphoretic, the patient is sweaty, then wipe that. You ask the patient to maybe wash their face first. Okay? Because that sweat alone, if you don't take it off, then that will already add to the impedance that will make the study really high impedance, and it will be a bad recording. You can even have sweat artifact where your signal is going to be going up and down like an ocean waveform. Okay, so if the patient is also sweaty, you make sure that the room is, now you get the room colder. You use a fan. And sometimes if the patient is just sweaty naturally, you need to start with alcohol. Okay, don't start alcohol all the time. You don't need it. But if the patient is sweaty, you mark and measure the head, then you wipe the spots with alcohol, and then you prep the patient. Excuse me. Now again, having the correct placement is important. So we will discuss the international system of measurement, the 1020, in a separate video, separate class, and I have that on video. I have actually 2 videos on that, so let me know when you are ready to watch that. And using the paste and tape, if you use too much paste and the electrode is sitting on that too much paste, is going to move a lot. So all night long you will have this respiratory artifact. If you have too little, then you can easily get an electrode pop, right? Where the signal will all of a sudden disappear and become square. Okay, so you just have to place enough that when you press on that electrode on the skin, you will see a little bit of scatter, just enough for you to use a tape or the hair over the patient's electrode, but just enough. Some techs use gauze, and then some techs use tape on top of all of the electrodes. But don't use EKG pads on patients' eyes. I saw that some techs utilize EKG pads on patients' eyes. They use it for the snore microphone. That's not nice. Now, equipment. We don't calibrate these systems anymore. When we used to use an old polysomnograph device, we used to calibrate because you have amplifiers and you have physical pens, and these pens have tubing inside where the ink comes out, and so we have to calibrate to make them even on the paper recording. So you don't have to do that anymore because we use everything digital, and you can quickly change and apply filters. But when you calibrate the patients, when you do patient calibration, you ask them to grind their teeth, open and close their eyes, hold their breath. When you do patient calibrations, this is mainly to check if you are recording and you are seeing these reactions from the patient clearly on the sleep system. That's what you have to be watchful of. And that's why it's important for sleep techs to know how to score studies. If you score studies, you will be a really good recording tech because you know exactly what makes it easier for the sleep technician scoring the studies and for the sleep doctors to read the studies, what to do to optimize and make it very efficient for them to read the studies. Okay, and the other thing that's important as a tech is your troubleshooting skills. I know some techs who prep very fast. They hook up very fast. But then they are always in the patient's room multiple times a night. Why? Because they hurry too much. They don't prepare well. If you prepare well, It might take you a little bit longer to hook up the patient, but if you don't have to interrupt the study to troubleshoot because something's popped and it's not recording in the middle of the night, that's better than to say you can do a hookup in 15 minutes, but then you're in the patient's room 5 times, 7 times, 10 times all that night. Okay? So troubleshooting, though, however, sometimes you cannot avoid it. Sometimes the electrodes that we use, sometimes they break, and sometimes the head box will pop off. Sometimes during the day, we don't know when the housekeeping are cleaning the rooms, then they might end up pushing or pulling the amplifiers, so that when you start a study at night, it ends up having a lot of artifacts that you can't control. So these are some of the things that you have to be mindful of. Now, recording is a continuous reading. Okay, some of us, when I was working nights, I will score my studies during the night. So I always have 2 patients, and I will score the study. And scoring the study is easy the more you do it. But by the time I'm done with my 12-hour shift, I already will have a report for the doctor. So the doctor will usually just check my notes to see if there's anything that they need to look over. I will mention, okay, on APOC 356 at 1:30 a.m., this happened to the patient. Please review. And sometimes the doctor will just, okay, there's nothing that needs to be escalated. The doctor will just really quickly browse the study and then create the interpretation. But for those who don't, and some techs work in a 10-hour shift environment, and so they can't really score us. That's too fast, especially if you have 2 or 3 patients. But when we monitor for brain waves, we look into the staging. So you have to try to stage at least. For me, as a tech, even if your doctor says, no, you don't need to score. I hear this in the Philippines because in the Philippines, most of the time, the doctors are the one who will actually stage and do the scoring, which is odd to me. Scoring is the sleep technologist's job. Once you're a licensed tech, the scoring the study is your job, not the doctor's. We monitor eye movements to ensure whether the patient is going into REM sleep or if the patient is in REM. Muscle tone helps to check whether the patient has arousals or if the patient is in REM or any tonic or phasic REM, etc. We also monitor airflow to identify any sleep disordered breathing problem for the patients. Signal loss, desaturations, arousals. Don't be afraid to reapply electrodes as much as we avoid it. Most of the time, we will attach both sides of the EEG. Per the standards, the protocol, AASM, you only need to show one side and record on one side. If you lose a signal, then you can use the other side. What we do in sleep is we already apply the electrodes needed for that purpose. You don't need to display them all. C3, if middle of the study you lose signal because the electrode breaks, you can just activate the C. Most of the time we got used to displaying both sides anyway. If you need to replace electrode, try to minimize turning on the lights. I used to work with this one tech in San Diego, and he goes in the patient's bedroom multiple times, and he's always upset. He goes into the patient's room and he turns on all the lights and then fixes the electrode. I always hated it when I see him troubleshoot like that. When you go into the patient's room, you knock just to make sure that the patient is awake. You don't want to touch the patient and the patient is asleep because they can get really startled or be scared of you. I always just knock a little bit and then I say, I'm coming in, fixing something real quick. And then I use a pen light. And usually before I come in, I already have a new electrode. I already will put the paste on it and I have a tape ready. So when I come in there, I know which electrode. I quickly take off. I prep the hair or the head, put my new electrode and attach it to the head box, and I'm out. You need to learn how to prep right before you go in there so that when you go and fix an electrode, it's not going to take you that long. And you do not need to turn on all the lights. And anything that's important and normal. For instance, you are doing a sleep study and you VTAC. Now, at least 3 seconds, 4 seconds left. It happens once. You need to be alert. You have to annotate. And you also check if there's any reaction to the patient. And if there's no reaction to the patient, then the patient's still asleep, quiet, fine. The patient ends up with VTAC and it's sustained for 10 seconds, you might want to go in there and check the patient. And the patient says, oh, I feel okay. Why? No, I just want to check on with you. But then you also monitor, and I will annotate my doctor, or if there's any on-call physician. I just monitored this patient for sleep study and I saw there's a VTAC. Okay. So some of the sleep labs are hospital-based where you can reach out to the ER doctors. I used to work in one of the labs, and when I noticed some really irregular pattern, I took a screenshot and I sent it to the ER and asked their doctors to read it to see if I should be concerned and send the patients instead of continuing the study. Okay? When you feel and you see something abnormal and you're not sure what to do, take the step and ask for help. Don't hesitate. It's better that you do that than to say, oh, maybe the patient's okay, and then you left it alone. And then the patient ends up with a stroke or a heart attack while you're doing a sleep study. We're getting closer. Now, in medicine, anything that you write, anything that you click, you annotate it, anything that you do, intervention, every time you walk into the patient's room and you adjust electrodes, you help the patient go to the restroom, anything you do, everything is legal. It can be used in a legal court. Remember that. Anything medical is legal. So we also monitor it through the video and the audio recording. So you have to be careful and professional. And these things can be very helpful for the doctor's interpretation. Let's say you have a patient and the patient started to groan all night. By the way, what's the terminology for that? Anybody know? When the patient groans and moans their sleep, what is that term called? It's a test question. Anybody want to try? Starts with letter C. Very good, Chris. Good. Catathrenia. Yes. I can already see an RPSGT here. Okay. Very good. Catathrenia. Yes. And they're moaning and groaning in their sleep. And sometimes it's harmless and sometimes it's harmful, especially if they have a bed partner or spouse. Okay, moving along. Good answer. Now, documentations that are mandatory, of course, is lights on and lights off, electrode placement or the montage, because these are all legal documentations, interventions. Let's say you have a patient, severe desaturations noted, estimated AHI for this patient is at 45 per hour. Tech will initiate CPAP for this patient due to high AHI. So you have to be clear in what you're doing with the patient on your annotations, okay? And then use of standardized templates. Some of these sleep systems are already connected to the electronic health record systems. Like here, we utilize, there's at least two major electronic medical record or electronic health record for the patients that we use. And these are either Epic or Cerner. These two, they are electronic medical record systems where the patient's chart is in that system. If the patient belongs to your hospital, that is the record for that patient. And including sleep, everything is also connected to that health record system. But they have their own template that you must use. This is just to say that you have to be aware when you input information, because it has to be accurate, because the patients, after they are seen in the sleep lab, these activities, these procedures will now be sent to the insurance companies for the sleep study to be paid for. It's not the patients that will pay the entire sleep study. They usually will have a small copay. Some of them, they don't even have a copay. It's their insurance companies that will pay for these devices or for the study, the sleep study, the treatment study, the MSLT, even the CPAP and the clinical management. And these are all paid for by the insurance. And the patients just pay a premium monthly, usually, to their insurance companies. To have a successful payment and reimbursement, you must follow some of the necessary standards or templates for the reporting. Okay, the insurance companies will ask, okay, you're charging me for a sleep study that you did for this patient, but I don't see your documentations on the lights on and lights off time. So they will reject your claim. They will reject the bill. So if you don't fix that, then what ends up happening is you will try to the patient. So this is the system here in the United States. It's called managed care. So managed care system is different from, let's say, a universal healthcare system. And there are many other countries that use universal healthcare systems, such as Canada, some parts of the Middle East. It's a government insurance system in the Philippines. They will pay for some studies, and then some they will not pay for. Some of the more expensive they won't. Okay, but here it's very complicated. The healthcare system is very complicated because you have private insurance, you have the government insurance, then you have the HMO, which are your really lower paying kind of insurance, and they don't usually cover all the expenses that the patients need help on. Anyway, we're not going to go too much further than that. And other more important to remember are your respiratory events, movements. Every time you go into the patient's room, make sure you say tech in patient's room, tech left room, or tech out of room. Okay? If you see any artifacts, and if you see artifacts, you need to troubleshoot. Okay? You don't just say electrode pop notice on C3 channel, and then you don't do anything. Sorry about that. So if there's any artifacts, the next thing is for you to troubleshoot and fix it. And if you try to troubleshoot 2-3 times and you can't fix it, then at least you tried. Okay? Never annotate an artifact and you leave it alone. Unless you're asleep, which you don't want to be asleep. Okay. And accuracy of your note-taking, very important. You can't guess on what you're trying to do or what you're trying to tell the doctor on what you did. You have to be very clear. Okay? And a couple more things. When we disconnect patients, never rush disconnecting the patients. You have to make sure that they are safe. And when you take up the tapes, the sensors, be mindful. Sometimes these patients will have some irritation because they've had the tapes and sensors all night long. Some of the cannula will rub off the patient's nose all night. You have to be just professional again and make sure that the patient is comfortable and safe on your care. That's the most important lesson here. And some sleep labs will do a post-study vital signs, blood pressure, but we don't necessarily have to have that. If the patient came in that night and you had to redo the blood pressure because the patients have really elevated blood pressure and you reported it, then it is good. It is a good idea to have a post-study vitals, just to make sure that before you release the patient, I have a record that the patient's blood pressure actually is now normal or not as high as the night before. So again, due to the legality of everything that you have done. And again, cleanup and disinfection, very important. When we disinfect, which we will discuss in another topic, disinfection requires some standards. When you deal with sleep, you are dealing with respiratory, technically. When you deal with CPAP, you're using tubing, CPAP mask. We disinfect things with the high-level disinfectant consideration. We must use high-level disinfectant, okay? There's low-level, mid-level, and then there's high-level disinfectant. We use chemical disinfection. Another form of disinfection is sterilization, which is a machine. And the other one is thermal disinfection, which is pasteurization and autoclave. Usually you use that with surgical instruments, very high temperature, but very short time. It kills all of the nasty stuff in the tools or the devices. But what's better for sleep products, if you reuse your tubing and your humidifier tub and the masks, we use what we call pasteurization. Usually the respiratory department, this machine, it looks like a washing machine, but trays. It uses medium to low temperature, but it stays there for a long period of time, at least 30 minutes to an hour. So it kills the bacteria, anything in there. for thermal disinfection. You can use Sterad, which is a machine, but it's very expensive, STERRAD. And then, of course, the most common is chemical disinfection because it's the cheapest. But when you use chemical disinfection, you have to use high-level disinfectant. One of the key ingredients is called glutaraldehyde, Glute, glutaraldehyde, RALDEHYDE, glutaraldehyde. And that's also a test question for those taking the examination, the RPSGT exam. You have to remember that chemical. Other than that, the summary, I usually type a narrative, like a short story. I have a template already, then I just change the information in it. I write a story for the doctor to read where I will say, patient came in with no signs of pain and stayed mostly supine all night, did not meet criteria for split, nadir or lowest saturation noted at 85%, snoring was moderate to loud all night, especially supine, and ended up with patient stating no complaints in the morning. You could do your own. And some doctors like that. You can ask your doctors if, hey doc, do you want a narrative report in the morning or just bullet points? Okay, some doctors won't even ask you for that, but just so you know. As we end our lecture, it is important to remember that having this strong foundation on knowing how to assess patients, knowing the importance of documentations, and knowing how you interact appropriately with the patients, having the skills in your measurement, in your techniques with the sensor application, in your skills in providing CPAP bi-level titration to the patients, and then creating appropriate note-taking, whether it's on the patient's chart or on hand. All of these is very important because everything is legal, and that we are the front end. We face the patients for at least 8 hours to 10 hours with each patient. The doctors will see these patients for 5 to 15 minutes. That's it. We interface with the patients so long, so they will get the majority of their education from us. So the more knowledgeable we are, the more we are in tune with what the patient wants to know versus what we give them, the better for the patient outcome. So that skill is very important as well, where you know what you know in sleep. But when some patients ask you some questions, try to see if they want you to answer them short or they want more. You don't want to give them too much because they will not remember everything that you said. But some patients, interesting. Can you explain that more? That's why it's important to have a good interaction with the patients. And the way they will interact with you is if they're comfortable. Again, it goes back to the entire topic, the discussion that we had. And then make sure that the patients don't feel threatened. Don't make the patients feel like when they ask you questions, you brush them over. You don't need to know that. You always respect the patients. If they ask you more questions, then try to answer. If you don't know the answer, then you don't try to create answers. You can tell them, I will get back with you on that. Or sometimes the patients will ask you for the test result and you cannot give them any test results, okay? And that's why we have to be careful. There's no reason for you to give the patient's test result because we are not in charge of creating the diagnosis, okay? I hope that's clear. Diagnosis belongs to the doctors or the providers' medical license, not from the techs. Careful measurement, careful practice of polysomnography leads to accurate and optimized diagnosis, treatment intervention, and clinical management. On that note, here are my references if you need it. If you find this beneficial, helpful, I would love your feedback. I'm always up for improving the presentations because I want to make sure that this is beneficial for you. So when I create my presentations, I make sure that I have content that is inclusive of the introductory materials to those who are just learning sleep technology. And two, I make sure that I have quite a bit of exam materials. I have a couple of hundred students that already have gone through my courses, but I have so many students that have taken the exam, the RPSGT. So I always include those things in there. And so when I ask questions, remember those questions because some of those are coming from the actual RPSGT exam. And I think you made a mistake on this. I'm very open to all that. I don't take that negatively. I always take things positively. Okay, that's how we will learn. That's how we can improve each other. I want this course to be very effective. And so for the future students, it will be even better. And that's only possible if students like yourselves will be also active in helping me improve things by giving me your insights, your thoughts, your questions, and your concerns. If there's no questions, then I appreciate you guys tonight. You guys are great.